I can't remember if that's a fall or I'm trying to remember. Yeah, in Michigan, she has a fall that takes her to the hospital. So one thing we were wondering is if you wanted to take that as the opportunity to have her diabetes now not be under control, and then be able to show more of your eCare plan changing and updating of the prior information and everything that you all do at that point, if that might be a good intersection point. With each of these scenes, we are not only trying to integrate the clients that are playing the parts of the EHRs and the various places like that, but we're also wanting to show the clients of the family being able to access the information. And you'll see kind of here that central blue box is our health data manager, where it's kind of the instance of the personal health record in our story, right? Where all that becomes the place where all of the data is stored and shared as she changes from Texas to Michigan and she goes from place to place, that at least everybody can pull her information from there, as well as contribute the new information to there.
So the data that's being stored, are you storing, condition resources and goal resources and things like that?
Only if your group, your IG has those in it, because the other IGs that we've integrating as far as the PASIO cognitive and functional status doesn't deal with the goals. There are some goals related to the advanced directives that does use the goal resource, but in a little bit different way than I'm sure yours does. And then the other one we still have to have a conversation with is the clinical reasoning track of how we're going to pull in that. We might be having some long-term, we still don't know yet how the long-term support system, if we'll have some of that pre-populated with bringing some goals in and data in that aspect. But we're kind of open at this point for how you would like to interface and design it. But we would like to, the plan is to have everything pretty much locked down as far as where the information will be going and what the main pieces of information are by next Friday, so that then we can focus on all of the sample data across all of these use cases that we will need to integrate to have ready to do all of this.
So
I'm sorry, I just one more question. I'm sorry. Does the functional status, cognitive status, or even some of the splash work, do you guys create observation or condition resources?
Their observation.
Okay.
Go ahead, Dave.
Yeah, those are largely observation based.
Okay.
If I may ask a question, so for each of the events, so you have about 6, 7, or 8 of them, there will be a whole lot of data being generated, and how are the data points of each of those events organized? Are they organized around an episode? So therefore you have an episode instance from which every pieces of data is point to, and so therefore when you query an episode, then you will be able to find all the data, or the data points being organized around a file composition. I'm looking for a sort of a guide to how we then can query the data at each of at the end of each of those events or episode of care, where you need to see a patient transition from one care setting to another. And if I am sort of at a different care setting, how do I do a query to find all the data that have been generated during that particular event?
Yeah, and that's part of what we really want to tease out of all this when you get all these things together. So I think, one of the things too that we have is reassessment time points that can help organize this information. And there are encounters associated with those, and then the reassessment time points break those up into smaller chunks, particularly like from scenes 1 through 4, and even 5. That's one episode really kind of where Betsy has a stroke and then goes to the hospital, then is discharged to a skilled nursing facility, and finally, and ends up at a home health agency. And then as a result of some things, she updates her advanced directives. So there's 1 through 5 sort of handles that case, and then in scene 6, she falls, and that basically includes scene 6 and 7, and then when she goes back to Texas in in scene 8, actually, in this table, then she is she has pneumonia, and that's a third scenario, and in each of those we're showing that information is going to be flowing. You should be able to query each of the various different encounters and reassessment time points that occur during this entire process.
When did she have the stroke?
At the very beginning.
Okay. All right.
I think it's scene 2 is the stroke. So she's in a home at home with long-term support services prior to the stroke.
Okay.
And we've got her personal advanced care plan being added, and that during that piece, and then the hospitalization with the stroke. And we're following the data as it changes with all of the different OASISs and MDSs and all of that between the skilled nursing facility and home health and all of that we're following, as well as integrating the splash data. So we could integrate data if you have it, but we would not be able to create specific data around your additional data around that piece of the clinical condition. If you want to look at diabetes, for all of these touch points that we're going to be having along the way, because there'll be lots of data pieces that are coming over these months that she's in all of these things.
So this is Dave Carlson. Go ahead, Stephen.
So I am particularly interested in the patient handover and transition of care, and how do the agency that's responsible for taking over the patient's care, even for a short period of time, how they are able to get the comprehensive pictures or holistic pictures about the patient through query of a file server. So I understand that you're still working it out, but if you have some conclusions after the May Connectathon, I would be very keen or eager to hear about it. So hopefully we can organize a report back sessions after the May Connectathon to the patient care group, and so therefore we can learn a lot more about it, and I can learn a lot more about it. Sorry, Dave Carlson, for cutting you off.
This is Lincoln Weed. In terms of that question of handling transitions of care, and also the prior point about how to different ways to organize the data, we haven't specifically discussed the alternative of organizing the data around problems on the problem list. And isn't that a way that would enable continuity between episodes, between different facilities and transitions between the facilities, and between different clinicians involved, so that for each problem on the problem list, the clinicians involved in that involved with that problem would have a chronological view of everything that related to that problem. And similarly, when you go from one facility, transition from one facility to another, the discharge summary from the former facility would enumerate what's going on or the status with each problem. And the receiving facility could simply drill down under each problem and see what's been happening and what's planned, what the plan of care is for that problem for the next steps.
It might well, so it might well be a way of organizing the data, but that way of that approach predicate on me knowing everything about the patient's problem, or I have to query the patient and then say that, look, give me all the problems of the patient, and then I have to work chronologically.
But if the record,
to find the information.
If the record was organized that way from the outset, so that you could see the past organized on that basis, then there wouldn't be, you would just be continuing that as the patient changes facilities, as the problems evolve, as
So,
Right, and that's, yeah. Go ahead.
Sorry, this is Jay.
Sure, that is sort of that is akin to you sort of dumping on my lap the entire volume of the patient's medical record. And what I'm after is not sort of having to sit through the entire volume of the patient's medical record. I want to know in the previous incident, say for example, scenario 7, I'm now in scenario 8, what actually happened in scenario 7, and for you to dump the entire medical record on my lap with the problem-oriented approach and ask me to work chronologically through those problems is sort of not very helpful to me in a time-poor scenario.
The problem-oriented approach does not require you to thumb through the entire medical record. It simply requires you to drill down on the problem you're interested in, look at the most recent entries. Those will tell you the current status of that problem.
Right.
So this is Jay. I think both of those approaches are looking at filtering the information filtering the information based on some axis of interest, and that could be time, and it could be problem, and it could be some combination of both. And the resources support either of those approaches. It would be interesting, I'm with Stephen, to see how that gets put together in an actual demo.
Yeah, so I think.
So as the patient goes through each of these scenes, you know, there's all of this information gets sent and stored in the standard patient health record. And so each of those is able then to query and get the information that they need from the, you know, and see what has happened in the past. So, I mean, we hadn't really thought so much about, you know, adding problem lists to this as, you know, but certainly we can do that. I think the, you know, the PASSIO project is sort of centered a little bit lower level than that, you know, about assessments and what, you know, answers to individual questions in those assessments, you know, in the case of advanced directives, the specifics around those directives. And we've added the reassessment time points to help organize that information across really long-term encounters, that's what you're going to see on, particularly on scenes 2 through 5, roughly. That, you know, especially in the skilled nursing facility and the home health agency, there's fairly long periods of time here, like April to mid-September for the home health agency, and February to April in the skilled nursing facility. And there's requirements to do reassessments and so forth. There's also going to be potentially parallel care that's happening as well that might require, you know, separate reassessments. And each of those reassessments, the eCare plan can be updated.
And each of those reassessments can be done on a problem-by-problem basis, and as can discharge summaries at each transition from one facility to another.
Right.
So I mean, I think part of what you're describing there is what you want what an application might do with the data. But this is really the exchanging of the data, and the applications that are part of the scenarios have that opportunity to demonstrate one aspect or another.
How the
But the
data,
underlying data is the underlying data. And, you know, because it's FHIR, a lot of things, you know, we can use it to innovate in many different ways. And that may be one good idea of many good ideas.
It's
So-
probably going to be more than the application layer problem. For anyone to be able to view the data, query and view the data in a meaningful way, the data has to be organized in such a way that it is conducive to the queries that needs to be done. Yeah, sorry that for drilling on the question for too long. I will stop here, but I just want to make it clear that there is a definitive need of knowing how the data is being organized to help the query that we want to do.
Yeah, and Stephen, you know, we would hope that we would be able to put together a pretty comprehensive summary of what happened at the Connect-a-thon, so that we would be able to present to your team, this group here, as well as other groups, as to what happened during the work group meetings.
That will be awesome. Thank you so very much.
And
And
I'm
I
not,
also suggest, you know, I know we have recorded many of the other earlier Connect-a-thons. We could maybe make recordings available. They're not that long, and you could get an idea of what the PASSIO group has done in the past. You'll get an idea of how the data flows. We've been using the ELTSS care plan in many of these Connect-a-thons. That's just one instance of a care plan. And I'm quite sure that the eCare plan can easily get added to the scenarios. It would just be another instance of a care plan. But I think if you actually see a demo of what's done before, it'll give you a sense of what this situation is likely to look like.
yes, and the request would be whoever, if it's Emma or whoever is going to be the official other person, that we can narrow down the exactly the point that data would be coming in and the types of data that's going to be coming in, and then so that we know how things are going to need to be exchanged at that point between what systems, and then that person, Emma or whoever, could work on providing us with the sample data that dealt with their IG, because we're having to, you know, integrate so many different IGs and data coming in. It's going to be quite challenging.
yeah, so we can work together as to, you know, how to get the data ready, or the data that will be exchanged.
So let me make a couple comments to this regard. So, you know, one of the challenges we will face, have to work out some processes for a sequence of steps in the scenario we've laid out here, how we can progressively add to the patient's record. And then if you want to rerun the scenario, in a sense of make changes to the process, the tools, the data, need some way to flush it out and start from empty again. This is exactly what we did in a HIMSS use case. I helped organize a patient-centered care planning use case at the HIMSS Interoperability Showcase in 2019. And in that scenario, and if those you know the HIMSS Showcase, we had to perform, if you will, once per hour for 3 days, and our presentation could be about 25 minutes long. So we did 21 complete end-to-end iterations of a scenario. We had 8 different participants from 8 different organizations, and actually not unlike this at all. We used a chronic kidney disease. We had Elsevier as one of the participants, for example, contributing clinical guideline knowledge to provide recommendations. Allscripts was providing some elements in here. Patient Link was a patient, but ultimately we needed some repository to hold the pieces that were coming together. In that case, in our example, in our use case, that was Perspecta as a company, and they were building toward a data sharing hub that we could all connect to. But at least to run that scenario, since we wanted to restart it from a known point at the beginning of each of these sequences, and we don't want to start with an empty repository. So what we could do in this case along that line is, so our project for multiple chronic conditions by its nature is a patient that has a history, that does have multiple chronic conditions, and then also recognizes events that occur over time for that patient, that needs to understand the backdrop of the patient's existing care and multiple chronic conditions and challenges associated with that, including restrictions, for example, on use of medications for pain for a patient that has kidney disease. So what we did in that case is have a baseline data as a set of FHIR bundles, and we had to have a server that we could flush out and empty at the beginning of each time we wanted to restart the sequence, and reload it with a baseline set of data. And that's what we already have for our project, is a set of FHIR bundles that are on a GitHub repository. And I routinely do that now, one script that bulk loads it into any FHIR endpoint. That's also what we did at HIMSS in the past. So we can bulk load the baseline data of a patient, not only with their problem list, but also some med list history that's appropriate for that patient. So we had a number of medications in the established med list. We also had some vital sign history, some lab history. So like related to diabetes, we have A1C and some glucose readings. Patient also had hypertension, so we have a series of blood pressure readings. But that's all in a baseline data set that we can bootstrap this configuration with. But the challenge we had then, and if we want to duplicate, looking at the scenario you have, if we want to run it more than once, or if we want to sort of restart it and rethink and then try it again, we need some way to flush out and create an empty data store and reload it from a known point and then run through these steps again. We also, I mean, with different participants, do we in fact want to look, we tried to do this in the past at the HIMSS, we didn't yet have the subscription infrastructure in place to look at subscribing to and receiving and creating updates from coordinated data stores, but we did have sort of one data store that all the participants contributed into. So at least, some thoughts around how to orchestrate the steps, and if we want to do it essentially more than once at the Connect-a-thon, we need to think through how we're going to do that.
Yeah, thanks, Dave. So so we've actually done some of that stuff in the past. Although we've used a different, we were using a different data store. Nancy Lush, her team had, we had used a server that she had had put up to do that, and was able to do exactly what you described, which was to clear out the data and load it in again. And we'll have to do that with the standard patient health record as well. And certainly if you have data that supports your I mean, it sounds like you have some great data with all the other stuff, and we'd certainly want to incorporate that in.
Yeah, we do have some baseline data, and we used Betsy Johnson was a patient that was originally created 2-3 years ago by NIH, and they've since renamed it to Patricia Noel. But I've done enough data mangling in the past that, I mean, within half an hour, I can take all our data set and just, search and replace and create a Betsy Johnson data set if that's what we want to coordinate this one. That's not too difficult to take the data set we have.
So I think the one thing that this is Nancy, the one of the things that comes to mind, because I'm pretty familiar with your Patricia Noel and with the Betsy personas. So Betsy already has her list of medications and conditions, and she has quite a long list of them. So we might want to just kind of overlay them to see how much work it would be to synthesize them into one patient. Because the things that she's already set up to have already relate to the story and all the sample data that flows, down to all the individual assessments and all the other aspects of her data. So we might just need to really look at what we currently have for data sets represent each one of those personas to figure out if we can overlay them. The other alternative is to kind of enhance the story a little bit and have an additional persona.
Yeah, and they have really been already synthesized. And I sent that, what was Betsy Johnson. That's exactly how I bootstrapped Patricia Noel. I took Betsy Johnson and I changed the name and all the identifiers, and then we evolved it from there. So there's no fundamental difference at this point already. So it's really taking a patient and agreeing upon what the baseline set is. And for our case, it's essential that patient has multiple chronic conditions. That's a cornerstone of our entire project, including chronic kidney disease and diabetes and hypertension, and then adding to that other events like stroke or other care that requires long-term facilities.
The main thing we would need to understand is, besides that front loading of the data in scene 0, of at what point would you be adding additional data in, and what method to write from the client to the server, the FHIR server that we have as the standard personal health record.
So in the past, we had just an open FHIR endpoint, so we could literally just batch load a FHIR bundle to bulk load it. That was straightforward. And then part of the scenario was applications that have the ability to write specific data from an application using a FHIR API to write into the data store. So
do you have one that you are working with? Because that's what we're still trying to identify, what implementers we have that have that write capability.
So part of our project, which we're working toward right now, is prioritizing goal initially, that especially from patient or a caregiver, to be able to contribute patient or caregiver expressed goals, which are then shared among all members of the team as part of the comprehensive care plan. So that's the first priority for us, and we really don't have a need to, for example, write lab results. Those are part of the EHR system. In our case, we're integrating and testing with Epic as the underlying data store.
So David, I think that you guys did develop a care plan app that wrote the care plan, didn't you? Or is that something that isn't really completed yet?
Well, it's the care plan. That's actually one of the
eCare plan.
Well, what is the eCare plan? Because with multiple chronic conditions, it's one of what caused NIH to even start this project 5 years ago. Was a patient has a diabetes care plan, a kidney disease care plan, and a cardiology care plan, and a surgical care plan, and there's overlap and contradictions and duplication across all these multiple. So what AHRQ is going to continue to build up this phrase of these over and over again right now is a comprehensive shared care plan. Part of which, what does that really mean as a care plan? And Emma, Emma makes some comments too. We're thinking more of the care planning process that contribute the data elements into care planning as a process. And what we've discussed a lot are how we can derive dynamic views of this data set from different specialty points of view, from a patient point of view, for different care events that occur over the period of time. But it's not like there is no document of a care plan. I mean, that is a question of what is a care plan other than a synthesis of all of the elements that contribute to the care planning process, which can be evolving hour by hour.
Here again, I think the problem-oriented approach provides an answer. What it involves is a care plan for each problem, but each plan is formulated by taking into account the other problems on the list. And that sort of naturally organizes the process without compartmentalizing the problems in isolation from the other problems. But it
Yeah.
also enables you to be informed by what the scientific knowledge about the particular problem. So,
Right, or the comorbidities of problems that have interactions, such as the patient who has chronic kidney disease and diabetes and hypertension. And if you look at the guidelines, which I have, there are a number of clauses in there that say if this kidney disease patient also has hypertension, then there may be some alternative recommendations related to medications or blood pressure and other management recommendations based upon the fact that there are comorbidities.
right.
So that's one thing we're trying to consider as part of this project, is look at the data elements. That is the thing this project led by NIH is focusing on, is for a patient with multiple chronic conditions. How can we better understand all the data elements that contribute into the shared understanding?
So the concept of a comprehensive dynamic care plan was conceptualized more than 10 years ago, based on what Dave Carlson, you have just mentioned, that a patient has so many, with multiple chronic diseases, have so many care plans, and none of the care plans or few of the care plans have any knowledge of the other care plans and what actually how the patient was managed with regarding to those specific issues. And so I created the concept of a care plan, the activities or intervention being conceptualized within a care plan may become an outbound risk to sort of another problems that the patient is being managed. A typical example is a patient with metabolic syndrome with a care plan managing metabolic disorders like diabetes would need to know about an orthopedic care plan where some of the COX-2 analgesics that are being prescribed by an orthopedic or rheumatologist on managing the patient's joint pain would have inbound risk for the metabolic problems. So that's against which sort of like premise that the concept of comprehensive dynamic care plan is being formed, in which this dynamic care plan knows about every other problems that the patient have, but not in the detail that a discipline-specific care plan, like a cardiology care plan or a metabolic management care plan might have, and yet have sufficient information to inform the discipline-specific detailed care plan as to what kind of inbound risks they need to be aware of. So that's how we have the concept of discipline-specific detailed care plan versus the comprehensive dynamic care plan. I know that this concept sort of have been bounced around for many years, and that's an issue that we have tried to address in the care plan DEM sort of 1.0, and we will continue to fresh it out and consolidate the knowledge, so therefore people are aware as to how those sort of different types of care plans are related.
So one of the things we wanted to do is, Dave, are you to show what the work we've done on the care planning app? Is that?
Yes, we wanted to at least provide some demonstration of what is currently available, what's being developed, and what would be available to Connectathon.
Great.
So I don't want to step through these slides as a kind of takeaway, they're kind of quickly, but so I'd maybe kind of back up one or two. I mean, who's driving here, but So, there was work done for 2 years, and then our team has continued this effort, kind of where the project left off. So this is kind of in work year 3, but the work underlying this was started by NIH more than 5 years ago around understanding data elements contributing to a comprehensive care plan and multiple kind of conditions. So next slide, just real quickly, that kind of point, there's 2 applications that had been developed and we're working from a third perspective now, but first is from a provider. And this would be an application that be launched as a Smart on Fire app from within an EHR system. This is actively being tested today, not in full clinical pilot, but is being tested connected with live patients and Epic at Oregon Health Sciences University. And Dr. Dave Dorr actually participated in this group several months ago, provide some of their perspectives. So he's leading the team integrating this application launched as a Smart on Fire app from within Epic. Provider perspective. And then the next slide is patient. And so it was patient an application, and we've been actively working because also the requirement now from NIH is also consider the caregiver participating on behalf of a patient or in collaboration with a patient. And so initially thinking about that as a separate caregiver app, but we're recommending now this be one application that can have different functionality as needed, so TBD, and ability for a caregiver to access data on behalf of a patient where they're the caregiver. So I'll show you some of that aspects here in just a minute, but that's what we're working actively toward right now. And as a kind of fourth bullet on this list, this is being designed, I'll demonstrate this based upon the requirements of the 21st Century Cures Act in the United States, where any patient has the right to access their clinical data via APIs, via an app of their choosing. So we're designing from that point of view where the application can be launched as standalone. It is fully Smart on Fire, can be launched standalone, connected with any EHR system or really any fire endpoint. And so we're working toward that type of a potential for all the US core and expanding on that in some cases as well. So that's kind of a summary that's decided to take away, but I did want to provide just a live execution of this. So if someone could give me share.
I think you just start sharing, Dave.
Yeah, well, someone had to
Oh,
yeah, had to stop sharing before I could take it. So I should have it now. So you should be seeing my screen. So really quickly, so from, I don't know what you're looking at from sandbox environments. I think probably many of you are familiar with Logica Sandbox. I've been using it at Connectathons for more than 5 years. There's the same platform is now also available under Meld, and there's some additional enhancements in that area. So we're currently using the Meld Sandbox from Interop community, although the exact same I'm showing here can run inside the Logica Sandbox. So within the sandbox, so we were talking earlier, we've got 3 patients put in here. One is our Patricia Noah I've been talking about. Also some of my prior work with VA. There's veterans that have some additional complex conditions. So I had some sample data, so to give us some additional examples and personas. We've got these 3 patients in the sandbox right now, and we'll make this more generally available during the Connectathon, and already have invited a lot of others to have access to the sandbox. But from the provider app, so this is launching it as if it's a physician launching this application from a system like Epic or Cerner or Allscripts. And so launching the application within the EHR system, Smart on Fire app, that would be a sub pane from the EHR system. So this is the design that was created based upon mock-ups from NIH a couple of years ago. This is a Smart on Fire application that is being tested, connected against a live Epic production environment within OHSU. So for loading this patient, a number of tabs on here. I'm gonna go this very quickly right now, given kind of where we are, because I want to spend maybe a bit more time on the patient and caregiver application, which will be kind of more easily available, I think, for a lot of you to explore and test. Tabs here, goals, still getting feedback. So this is documenting feedback. So RTI in collaboration with OHSU has been running structured interviews with a number of physicians from different specialties and primary care to get their feedback on this from their perspectives, both specialty and primary care. So different perspectives on the data. And as Linda said, well, where is the care plan? I guess that's still, the discussion to be had is when I have patients with multiple chronic conditions being treated over time. This project is focused on standardizing the data elements that contribute into care planning as a process and exploring some thoughts about how one could provide different dynamic views of these data from a specialty or from a different role perspective. So again, really quick whirlwind, but this is what's running against our sandbox and is being tested. I want to show you then from the patient perspective, and so this is a very quick whirlwind, trying to keep us within our time initially. This is actually launched as a standalone application. Later, it's a URL with a endpoint parameter. So this is a standalone Smart on Fire app, be launched by a patient or a caregiver. This is pointing to the same sandbox. This is using a secure Smart on Fire OAuth 2 connection to it. So looking at Patricia Noel, this is formatted from the priority of a mobile application. And I've tested this pretty extensively over a range of smaller mobile devices that it presents well in a smaller mobile footprint. And it's a web application. It's not a native app at all. It's just a web application. So I'm running it just in the Safari browser right now. So this application is reading then from the same record and just exploring different user experience design on this right now. We're actually looking to hopefully add to our team someone who can focus on the user experience feedback and the presentation of this in collaboration with working with patients and caregivers. But it's going to get really, really fast on here, but looking at the goals, putting quite a bit of effort right now into how goals would be presented, including goals that are general text as expressed by the patient. So this was a goal added by the patient to our caregiver, just simply say, I plan to walk half a mile every day. Other goals that are quantified and measurable, such as A1C goal with a target of less than 7%. And this application using the link code looks up the most recent observation corresponding to that target and says that the most recent value as of January 25th was 8.2%. So trying to combine some of the different data elements for goal-oriented care planning. Conditions as a problem list, but a patient with multiple conditions, looking at a medication list. Again, these are all just retrieved from the FHIR queries to the same server we just looked at a minute ago from the provider perspective. There's still kind of work underway to think about what are the interventions that can and should be presented here from the patient perspective. Health status, looking at lab results. These are determined by value sets published as part of our implementation guide. So a subset of labs based upon the labs that were prioritized by the technical expert panels at NIH, and then value sets being developed by Gay Dolan and Emma Jones and others to define the value sets, in this case of the link codes. looking at the vital signs, the most recent value in this case for these values. And this is a whirlwind tour, but I do want to show you right now exactly the same application being launched, pointed to the EPIC sandbox. And so this is available as an open sandbox to anyone developing against EPIC. So logging in as one of their test patients is all fully documented on EPIC's site. But I want to show you in this case is from the proxy user, and like most EHR systems support that. We're using that right now to enable a caregiver to have access. So in this case, this is Jason Argonaut, name and data all chosen by EPIC in their sandbox. We can't add data to this, but use what they have. So Jason Argonaut is the patient, but he has proxy access to Jessica, presumably his wife. So I'm actually going to log in. So Jason is logging in, but he's choosing Jessica for opening this application, and he can do exactly the same thing in the My Chart portal, or and most EHR systems allow a similar capability. I won't go in all detail on this. These pages are presented by EPIC. It's a requirement of the 21st Century Cures Act for patient-facing applications that the patient be informed about who is providing this application, if other than their healthcare provider organization, and also to make informed choice about what data the application is asking. And they have the opportunity to unselect elements within this, say, I don't want to give this application access to my social history, and I don't want to give it access to my immunizations, for example, and they can make those individual selections. And then I'm allowing access to everything else. And now our application connected directly to EPIC, and again, very limited data in this case, but it does have a very limited problem list, medication list, and this is all for Jessica. So it's Jason acting as a caregiver for Jessica and viewing all of the elements of her care plan. Again, limited data unfortunately in EPIC, but otherwise the same application being available. For those of you I haven't tested the Cerner connection in a long time, but something is not active there. I'll have to re-verify that, but the same application I have tested successfully against the Cerner Fire Sandbox. The same application also is able to connect to any of 350 EPIC endpoints currently for testing. So in this case, if you are a patient of Mass General Brigham, you could launch and run the exact same application right now against your medical records at Mass General. So looking toward, really disseminating an application like this, making it widely available, and kind of drilling into the last comment here is really thinking about this, especially from the goals, and the goals as determining, priorities and direction within the care planning process, and in this case, especially from the patient or caregiver perspective. But this would be available to connect really to any fire endpoint, or quite easily configurable to connect to any fire endpoint in our Connectathon environment. So that was a stream of consciousness. So hopefully that give you a quick overview.
Very cool. Very cool. Thank you.
So I just kind of last point, we're really trying to think about where do assessment observations. So actually I have a tab in here for apparently calling it surveys, but and can absolutely read survey observations, looking at the most recent draft of US Core for assessment result observations, typically extracted from questionnaires, which I think is essentially what is a core focus of PASSIO. So I'd like to work with you between now and the Connectathon to say what certainly expand on this to present as part of the steps that you've described as well, your sequence of new observations. And then from our planning perspective, those observations are often in the basis for, or the evidence for creating perhaps a new concern, and then creating a goal to address perhaps an issue that was identified from an assessment. So we'd really love to work with you on kind of that part, connecting that part of the observations and assessments into driving a care plan development.
Okay, great.
Right.
That sounds great.
Thanks, Dave. That's very, very good. Any questions? I know we're at time almost.
Yeah, so I'm just
So-
putting in some links to various things.
I guess, like the app that was developed, I know, I was part of that group that Michelle Doherty ran, I think on RTI. That app that you demonstrated, the first one you demonstrated, Dave, that has capability of creating a care plan and writing it to a fire.
This one does not. It wasn't developed by RTI. This was developed by Cognitive, under contract to NIH.
Okay. But is that app available to use in the Connectathon, and can it?
Absolutely. Everything I've showed you is open source.
Okay.
And so yes, it's available. The provider app currently requires a bit more configuration, but we currently have this running on an Azure hosted service. But yes, this app can absolutely be available Connectathon as well as the patient app.
So, I mean, in terms of trying to write that new resource type of the eCare plan, this app could create an eCare plan that then could get interwoven into our story and the process, correct?
Yes, but so go back to the question, what is an eCare plan for a patient with 6 conditions and some new acute care requirements? Is it one comprehensive care plan that encompasses all of that? Or do we want to look at from the problem lawyer perspective? That's one thing we've considered is driving a dynamic care plan from a condition and using relationships then. So what we've talked about in the last Connectathon is say look at the relationship from a goal, that a goal addresses a condition, that medications and service requests have the reason for a condition, so that we can essentially derive the relationships of all of the care planning elements that are in support of that condition. So I guess I ask, what is that's what we're looking at from a dynamic derived care plan from a perspective.
Yeah, and I think it's if I can be so bold as to say, I think it's a catch-22. It's whatever you want to present that can be integrated into the user story that we already have. Which I'm thinking the Passio group is pretty open on whatever you would like to do that makes sense. I think probably as long as we're not going to get too complicated, because this story is already very complicated.
Yeah, so it's really thinking about how to present, perspectives on the content. And so as we were talking earlier, I got Patricia Noel. So if we don't yet have like assessment survey, but so as Passio observations are created at a point in the story and contributed, from the care planning perspective, much of it is oriented around goals and conditions or health concerns, and then medications and other interventions created in support of that. So, anything that's contributed each step along the way, and is immediately available in an application like this to show. We don't yet have a subset views, but that's something that certainly wanted to explore.
But the
I would
challenge
guess this application would just work with our current data set.
Absolutely. Pointed at if you identify your endpoint, containing your data set and point this application, it will display anything that it currently supports.
Right, that's what I would expect.
Right.
Yep.
So that gets again to the point that we seem to not have the problem of people to show what's in there, but still identifying the process by which we model, new data being entered in. And to your point then too, of being able to erase it, if you want to restart again, because you can only push it, once.
Yeah, and that's what we did in previous connectathons where we we did do a 16 use case earlier where we did things around a slightly simpler use case where we did stuff around cognitive status and functional status and reassessment time points. So, and we were able, that's what we did. We started from, we were able to reset the server.
So in order to prepare for that, to be able to point either one of these applications at some server that we use to share during the connectathon, there's a Smart on Fire app. I get set to an open endpoint if that's what you use, which would make it easier, but it also supports auth 2 authentication. If we have that set up.
Yeah, the standard personal health record server should check all those boxes.
Okay, so it's a matter of configuring it and a typical Smart on Fire app of getting a client ID and identifying this application. I've done that over a series of different servers, such as Epic Sandbox, Cerner Sandbox, Logica, Meld.
Okay.
Yeah, it's all just standard Smart on Fire. So
exactly, yeah, it's standard configuration. So we can anticipate what those setup is. We can have that prepared and ready to go and tested before the connectathon.
Yeah, our goal is to have everything, functionality complete by the week before, so that we can just focus on bugs after that.
Yeah, and questions that come about the coordination across the participants.
Yep.
So would this then create the new content as it goes through the various scenes? Or only pull the content that was already created? That's where I'm still, I guess, conceptually.
I think this app he's showing right now pulls content, but the other app that he showed earlier can create content. And I think we want to be explicit about
the provider one, you're saying, can create the content.
This one does not. The provider app in the TOPA is also read only. The data, the content's primarily created within Epic.
Oh, this isn't. I see. This isn't creating the data. I see.
Yeah.
I see.
So we're still missing. We're still missing the client that's putting in the data.
Right. At least in our pilot test environment, that client is Epic.
I see.
Yeah. So, okay.
So what we've done in past connectathons is we have a little utility that will read something from somewhere up from one place and put it in the other. We use that quite a bit in the earlier connectathon, Dave. So
that's what the Sandbox does as well.
Yeah.
Sandbox has an import tab. You can import, any Fire bundle. You can use command line. I mean, that's how I bootstrapped all of these data. I didn't type any of them in. It's a pretty comprehensive data set, and they're just Fire bundles on GitHub.
Right, but I mean, what it does is it facilitates the story where you can say this plan was developed at this node, and we can bring it into this personal health data record.
Absolutely, you can do it, through, like in this type of environment, Logic or Meld. You can import. You can literally copy and paste a Fire JSON or XML bundle here and hit load, and everything in that bundle is loaded into the server. So, yeah, we've used something like this before to show stepwise, progressively adding data into the server.
So if we had two servers, one that held all the data that's going to be kind of receiving, right, as things get added, and another one that holds all the data that we're going to move from it, pretending each time it's this other, aspect that's loading it.
Or files. In most cases, I do it from JSON, files.
Yeah. So in reality, though, a lot of what we're demoing, we actually have different vendors write sections of the data. Like you're going to have reference implementation writing the assessments, Dave, right? So I think what we did, because there's so many assessments in the user story, we demonstrated the reference implementation, completing the data and writing it to the endpoint. And then we took additional stories and just kind of mass moved those additional stories. So we kind of did a combination. So we actually demonstrated an application, creating the data and writing it. But just to kind of not be doing that all day long, we automated the rest of it.
Sure. Well, we
Right.
hope to find additional partners here that have, for example, fire questionnaire, the ability to extract observations from questionnaires and write them to an endpoint. I mean, in principle, we'd love to identify additional participants who had more tools like that.
No, I think that we already have, right? We already have
Right.
many
So if you
participants.
point at this endpoint, then it's an application driven
Right.
content creation.
Yeah, that's what this is defining.
Yeah, I mean, yeah, our assessment app takes the result of the questionnaire response and then blows it up into the various Passio observations.
And then kind of write it to a fire endpoint.
Yep.
It's,
Yeah.
Yep.
So in principle, you could point at the sandbox that can support an R4 endpoint.
Mhm. Cool. Well, I think there's lots of opportunity here.
Yeah, it's good. We've had this, coordination. The more preparation you do for Connectathon, the more likelihood we have some connections occurring.
Yeah, and I think, certainly what we've done over time is we've sort of, lately we've been focusing on more of individual cases, but earlier on we were taking a case and then building upon, each Connectathon, building upon it, and adding more stuff. So, there's lots of opportunity here to add more stuff.
Absolutely. And we intend to, plan for a September Connectathon as well. So this is a milestone along the way.
Yeah. And that might work out well for us because, our July Connectathon is going to be focused on advanced directives. So we won't be doing the CMS Connectathon, the July CMS Connectathon. We're going to focus on advanced directives, not the integrated use case that we're talking about here.
So are you leaving your advanced directive work open enough that it will include advanced planning things like a birth plan or something like that? Or is it only about Medicare kind of patients, advanced directive things? You know what I'm saying? Are you doing it in such a way that it can be used for any advanced directive or any advanced planning?
So it does have a section which is the patient's priorities and goals,
Okay.
which is kind of open. It could be anything from, hey, if I'm ever hospitalized, I want to see my grandkids via video screen, and if I'm out of town, things, non-medical type things. The content generally, for most of the other aspects, is geared towards those concepts, more so towards end of life or afterlife, but also in the senses of emergency when you can't speak for yourself. So it's primarily geared for the scenes where you are unable to communicate for yourself, and therefore this plan takes over.
Oh,
And I'm thinking what you're thinking of there is more just the preferences being when you can speak for yourself.
yeah, and advanced planning, or even when like somebody, because of religious reason, I'm getting admitted, I don't want to get blood transfusions. I can speak for myself right now, but I'm just letting people know.
Yeah, I mean, those kinds of things have been discussed. So, yeah.
And I know because we're doing some work in maternity health, maternity care, and have been having discussions about advanced planning for patient preference, birth plan preferences. I prefer to have the baby at home. I prefer, those kinds. I would like to have the baby at a birth center, that kind of thing.
Yeah, the January, I mean, the July Connect-a-thon, we're going to be focusing on our STU2 version of that implementation guide, which is focused on practitioner authored information. So portable, portable medical orders for life-sustaining treatment and things like that.
Okay. Well, thank you. I know we're way past time. Sorry.
No, this is
Right.
great. This is great. Thank you so
Good.
much. This is great.
Yeah, thank you guys. Thanks, Dave, for the demo. Anything else? If people are wondering, the care planning track is called Care Planning on the Connected page. So please sign up to join us. And I think we're supposed to get together and work on sessions right this week as well, right, Linda?
Yes, you should have the invites for Thursday of the tech team call, and then Friday,
Okay.
11 for the more use case aspect of it. And if you can email me if there's any conflicts of timing, because we're turning in our track schedule tomorrow. As we're trying to coordinate across multiple groups that we're doing from a time perspective. If you weren't on the Passio call today, I can shoot you the slides about that, just so you can just see the times that we're looking at to be submitting tomorrow.
No, I was on the call today.
Oh, okay.
Okay. I'll let them know. Thank you so much for sharing that.
Mm-hmm.
Yeah, no, thank
Thank
you.
you. Yeah, thank you, everyone. It has been a very interesting discussion and a lot of knowledge being shared. I look forward to, we patient care look forward to updates from you guys as your preparation goes ahead, and also in particularly the outcome of your connected.
Thanks,
Yep.
Stephen. But thanks, everybody. And we're sorry again that we ran over.
Very good. Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.
Thank you.